Hello everyone, I'm Dr. Amit Pandey and I'll be talking about a very important ocular emergency, which is acute angle closure glaucoma. A patient with acute angle closure crisis can be because of primary or secondary causes, more common being the pupillary block primary acute angle closure crisis. The mechanism being uh, the contact between the lens and the iris prevents the fluid, the aqueous fluid, from coming from the posterior chamber into the anterior chamber, which gets collected behind the iris. This excess fluid pushes the iris against the angle and completely closes off the outflow. This leads to an acute buildup in intraocular pressure. Secondary glaucomas can also present as an emergency, which could be because of uveitic causes, can be lens-induced glaucomas, can be malignant glaucomas, neovascular glaucomas, as well as drug-induced idiosyncratic reactions can also come with bilateral acute angle closure glaucoma. The treatment of these secondary causes would differ from the primary one, and today we'll be discussing mostly of the primary pupillary block treatment. These are the risk factors. Mainly, small eyes are at a higher risk of developing acute angle closure glaucomas. A patient with an acute angle closure crisis would present with rapidly progressive impairment of vision associated with pain, redness, photophobia, colored halos, nausea, vomiting, and a history of similar complaints in the past, which was aborted by going into a dark room or after sleeping. The signs would be circumciliary congestion, corneal edema, fixed oval semi-dilated pupil, shallow peripheral anterior chamber, aqueous cells and flare can also be there, and the pressures would be very high, more than 40 to 50 mmHg. On gonioscopy, if it is possible, we will see a completely closed angles, and the gonioscopy of the other eye would also show occludable angles. The primary management would be to immediately decrease the intraocular pressure because it's an emergency and can lead to permanent vision loss very quickly. We bring down the pressures with oral acetazolamide, 500 mg stat is given if there is no contraindication like kidney ailments or sulfa allergies. Intravenous mannitol 1 gram per kg is given with blood pressure monitoring continuously. And contraindication would be cardiac insufficiency or again kidney problems. Topical beta blockers are instilled, and topical steroids are also given to decrease the inflammation. Once the pressure starts decreasing, the corneal edema starts decreasing, topical pilocarpine can be started, 2%, 1 drop every 15 minutes with 2 to 3 doses should be enough. And when you see the pupils constricted, we do a peripheral laser iridotomy. Usually a YAG laser or an argon laser is used with an Abraham lens. The power for the YAG laser would be around 3 to 9 millijoules, but it varies according to different machines and different surgeon choices. The endpoint of the PI would be a sudden gush of aqueous that you see. And the minimum size, the ideal size would be around 150 to 200 microns to prevent any further angle closure. Once the PI is done, if still the angles don't deepen, a peripheral iridoplasty can be done, but the availability is an issue. If still the pressures are high, we start anti-glaucoma medications. And if we can control it with glaucoma medications, and then you see oppositional closure only without extensive pass, the lens is clear, we continue with the anti-glaucoma medications. But if the patient has cataract, we would prefer doing a early cataract surgery of early phacoemulsification. Synovial closure, if there is extensive peripheral anterior synechiae and the lens is clear, we continue with the glaucoma medications if the pressures are controlled. And if there is a cataract, depending on the amount of nerve damage that has already happened, a phacoemulsification with or without a trabeculectomy is done. If the pressures with medications are not controlled and you see an appositional closure only, a clear lens extraction or a cataract surgery can be done in these patients. Synovial closure, if you are dealing with that, then with a clear lens, you do only a trabeculectomy, and with a cataract, you do a phacotrabeculectomy. These are a few articles for further reading. Thank you for this opportunity and for this wonderful initiative by YOSI.